to share the experience of LRS Institute in managing the XDR-TB cases. It is a very, very small experience of few cases only, but still we thought to share with you, and then we'll proceed ahead. You see, as you see, the current accepted definition of XDR is resistance to INH and rifampicin, and any of the fluoroquinolone and at least one of the 3 injectable drugs. That's accepted definition of XDR. And there is a term which is also accepted well by the clinician, is the pre-XDR-TB, wherein besides resistance to INH and rifampicin, the patient is found to be resistant to either fluoroquinolone or one of the injectables. And as we know, the LRS was the first institute who reported the experience of treating MDR-TB cases in the field conditions. And we had enrolled around 126 patients between January 2002 to December 2006, and followed these patients also for another 2 years, so at least 7 years. And we observed that by using a protocolized regimen, around 60% of the patient could be cured, but the death rates and default rates were very high. And the reasons for the same were discussed, and this study formed the basis for framing the national DOT+ guidelines at that time. So the next challenge in front of this LRS Institute was to talk about the XDR tuberculosis. And as we all know, there are several management issues when it comes to treating the patient with XDR-TB. The proper history of second-line drugs is not available most of the times. Like for first-line drug, we know how to ask the history, but for second-line drugs, usually we are not sure whether the correct history has been taken. And the DST against second-line drugs is a big question, especially in our country, and we know that for several years, the TRC was the only institute in the country which was accredited for carrying out DST against second-line drugs, and Dr. Manu is sitting here, chief of our microbiology lab. Now, the LRS is the second institute who has joined this path, that now we are also accredited to carry out the second-line drugs. Although we were doing it for some time, but the actual accreditation reached recently only. Then, of course, in TB we have in vivo in vitro mismatch, and that is applicable to XDR-TB also. Very limited drugs are available by the time patient has XDR-TB. Very limited drugs are available, and the clinician is sometimes very much cornered what drugs to use, and sometimes they have to use the drugs where the patient may have taken it earlier also. And very limited experience is available in the country. Very few physicians are there who have experience of using them in a protocolized way, because these drugs have not, the so-called group 5 drugs in the WHO guidelines has not been used by most of us. And we at LRS, we feel we need to learn more about these drugs which have a lot of side effects and which are quite expensive also. Then regarding